Hello guys, welcome back. Now in this video, let's begin with the RBC disorders. Okay, so the most important RBC disorder that we are going to discuss in this video are going to be anemias. Okay, anemias. So let's begin. Anemia. Same. What exactly is anemia? Okay, anemia is defined as hemoglobin, okay, less than 13.5 grams per deciliter. Okay, less than 13.5 grams per deciliter in males. So in males, if you have less hemoglobin, how much less? Less than 13.5 grams per deciliter. If this much hemoglobin is there, then it should be called as anemia. Okay, less than 13.5. The same way, if a female, if she is having less than 12.5 grams per deciliter in female, then it should also be considered as anemia. So now these fellows are having anemias. Okay, these persons are having anemia, sir. Now, what if the person is having anemia? Imagine there is this one person who is having anemia. Now, what are his complaints? See, clinical features. The clinical features are going to be something like this. So, these fellows who are having anemia, they are going to mainly show the symptoms of hypoxia. Okay, symptoms of hypoxia. So, what are the symptoms of hypoxia? Which hypoxic symptoms are going to be seen? Say, as they are not having enough amount of hemoglobin, we all know hemoglobin is the one which carries the oxygen. So, hemoglobin is less, so oxygen carrying capacity is going to be less, so there is going to be anemic hypoxia, anemic hypoxic conditions in the body. So, these patients, whenever they want to do some work, okay, these persons, whenever they want to do some work, they will get fatigued easily. So, the patients are going to have weakness, okay, fatigability. Easily the patients are getting fatigued, sir. Okay, fatigue is going to be there. Sometimes these patients even have, like, the respiratory difficulty, like dyspnea can be seen. Okay, next, what else can be seen in these patients? Headaches. Okay, so these patients are having headache, lightheadedness. Okay, lightheadedness can be seen. See, it doesn't matter what is the cause of anemia. Okay, or it doesn't matter what is the type of anemia. See, there can be microcytic anemias, macrocytic anemias, normocytic anemias. There are different types of anemia, sir. It doesn't matter what is the type of anemia. If the patient is having anemia, means the patient is going to have the same universal symptoms. These are the universal symptoms: weakness, fatigue, okay, lightheadedness, headaches, nausea. Okay, so these things are going to be very much common in every person who is having anemia. Now, having said that, how many types of anemia are there, sir? Okay, usually anemia is classified into how many types? Before telling you that, let me tell you what is the size of the RBC. Okay, or I should say, what is the volume of the RBC? See, normal RBC, okay, the volume of this normal RBC is going to be somewhere between 80 to 100 femtoliters. Okay, this is the normal size of the RBCs. If the RBC size, if it is getting less than 80 femtoliters, okay, if the RBC volume, I should say, if it is getting less than 80 femtoliters, then are they big RBCs or small RBCs? Now the RBCs are going to be small. So these small RBCs, now they are called as microcytic RBCs. Okay, they are microcytic cells, microcytic RBCs, and this anemia is called as microcytic anemia. Okay, microcytic anemia, sir. Next, if the RBC size, if it is more than 100 femtoliters, means bigger RBCs or small RBCs. Now bigger RBCs. Okay, now these anemias are called as macrocytic anemias. So tell me, how many types of anemias are there? Sir, there are microcytic anemias, macrocytic anemias. In microcytic anemias, the size of the RBCs is going to be less than 80 femtoliters. In macrocytic anemias, the size of the RBCs is going to be more than 100 femtoliters. And there are anemias, okay, there are anemias where the size of the RBCs is still normal. Okay, anemia is there in the body, the hemoglobin is going down, but still the size of the RBCs is maintained normal. Okay, so those anemias are called as, okay, those anemias are called as normocytic anemias. Okay, normocytic anemias. So, microcytic anemias, macrocytic anemias and normocytic anemias. These are the different types of anemias based on their size. Having said that, okay, next, what else I should teach you is, look, what is MCV? You know it. Okay, MCV is mean corpuscular volume. Mean corpuscular volume. What is the normal mean corpuscular volume? Mean corpuscular volume means which corpuscle? Red blood cell. Okay. So, the mean corpuscular volume is 80 to 100 femtoliters. Okay. Next thing which I want you to know is MCHC. Mean corpuscular hemoglobin concentration. Okay. Mean corpuscular hemoglobin concentration. Okay. See, let me explain you the concept, sir. The concept here is, see, this is the normal RBC. In the normal RBC, on an average, how much hemoglobin is there? Okay, on an average, how much hemoglobin is there? So, that is mean corpuscular hemoglobin concentration. Mean means on an average. In the red blood corpuscle, how much is the hemoglobin concentration? Mean corpuscular hemoglobin concentration. Now, let me tell you, sir, if the size of the RBC, if it is getting decreased, okay, the size of the RBC, sir, because of some reason it is getting decreased. If the size of the RBC, if it is getting decreased, what happened to the hemoglobin concentration? So, the volume of the cell is decreasing. As the volume of the cell is decreasing, the hemoglobin concentration increases. So, if you decrease the volume of the RBC, getting smaller size, the mean corpuscular hemoglobin concentration increases. Okay, size decreases, mean corpuscular hemoglobin concentration increases, sir. Okay. Now, after this, without any further ado, now let us begin with the topic of microcytic anemias. Microcytic anemias. So, in the name itself it is there, microcytic anemias. Sir, what exactly is microcytic anemia? Microcytic means the size of the RBCs, anemia is there, the size of the RBCs is getting decreased. How much decreased? Less than 80 femtoliters. Okay, less than 80 femtoliters. Now, here itself I want you to explain the concept. So, the concept is, why microcytic? Why small cells? Why small size? Is because, okay, is because, let me explain you in this way. See, for example, in your family, okay, in your family, there are 5 people. You need to have certain sized home, okay, normal sized home. So, 5 people is something normal, okay, you are going to have a normal regular kind of apartment or individual home. But example, if in your family, if there are 10 people or 15 people, you not like, you should need not an apartment, so you should actually need a villa to accommodate so many people, okay. So, what I am trying to put into your mind is, more the number of people, more volume you need. Less the number of people, less volume, house is enough, okay. In the same way, in the RBC, who is present? Hemoglobin. If the amount of hemoglobin is going down, means hemoglobin production decreased. If hemoglobin production decreased or the amount of hemoglobin is decreasing, now to accommodate this hemoglobin, you need bigger RBCs or smaller RBCs? Automatically small RBCs. So, the entire point which I want to put into your mind is, sir, in microcytic anemias, the cells are microcytic, the cells are small in size, because in microcytic anemias, the hemoglobin production is going down. So, it is a problem with the hemoglobin, less hemoglobin production, okay, less amount of hemoglobin, so small size RBCs, okay. Now, here itself, I want you to know, sir, what exactly is this hemoglobin? What exactly is this hemoglobin made up of, sir? So, let us write the full form, hemoglobin, okay, that is the HB. So, this hemoglobin, it is actually made up of 2 things, sir, okay, it is actually made up of 2 things. What is that? Heme plus globin, heme plus globin. Now, what is this heme and what is this globin? Sir, globin is a protein, okay, globin are the globin chains, okay, globin. Heme is what? What exactly is this heme, sir? Heme is made up of 2 things, iron and protoporphyrin, okay, iron and protoporphyrin. And what is this globin? Sir, globin is a protein, okay, globin is a protein. Heme is not a protein, okay, heme is made up of iron and protoporphyrin. Globin is a protein, sir. So, how many types of protein? So, in the globin, there are alpha globins and beta globins, alpha globin and beta globin. Okay, two alpha globin chains will be there and 2 beta globin chains will be there. Okay, so this is basically hemoglobin, sir. Hemoglobin is made up of heme plus globin. Heme is made up of iron and protoporphyrin. In the protoporphyrin ring, actually there is a protoporphyrin ring in which the iron is sitting in the center. Okay. Next, what I want you to know is, sir, what are the examples of microcytic anemias? Okay, you know why microcytic anemias? What are the examples of microcytic anemias? Let me put it this way. The examples of microcytic anemias are, first one, iron deficiency anemia. So, iron deficiency anemia, anemia of chronic disease, okay, anemia of chronic disease. Next, sideroblastic anemia, and the last fellow is thalassemia. Okay, thalassemia, sir. And here I want to add one more miscellaneous thing which is called as lead poisoning. Because in many exams this question was asked, lead poisoning, okay, lead poisoning can lead to microcytic anemias. It's not an anemia. Lead poisoning is not an anemia. Lead poisoning will lead to anemia. But the reason why I have kept you here is there is a mnemonic. There is a very famous mnemonic which will be which most authors use. So it is called as SITAL. Okay, this is SITAL. Okay, SITAL. So what are the examples of microcytic anemias? SITAL. S for sideroblastic anemia, lead poisoning, anemia of chronic disease, iron deficiency anemia, and thalassemia. Okay, these are the examples of iron deficiency anemias. Now, in all these conditions, what is one thing common, sir? The one thing common is the hemoglobin. The hemoglobin production is decreased, affected. The hemoglobin production is decreased. Without hemoglobin, automatically the size of the RBCs are going to decrease. Simple as that. So, without any further late, now let's begin with the iron deficiency anemia. Okay, what exactly is happening in the iron deficiency anemia? You already know it. So, hemoglobin is made up of what? Look here. See, hemoglobin is made up of what? Heme and globin. Now, what is the problem? Where is the problem, sir? See, iron deficiency. Now, the problem is here, sir, iron deficiency. When iron is not available, heme is not there. Simple, iron plus protoporphyrin is the one which gives the heme. So, when iron is not there, there is no heme. Without heme, no hemoglobin. Without hemoglobin, anemia. So, small size RBCs. As simple as that. So, iron deficiency can lead to microcytic anemias. So, let's begin with the topic. Iron deficiency anemias. Okay? Iron deficiency anemias. Now, iron deficiency is the most common nutritional deficiency in the world. It's the most common nutritional deficiency in world. Before going into the causes of iron deficiency, why iron deficiency, you need to understand how normally you absorb the iron, how you get the iron into your body and from where it is absorbed and how it is transported and where it is stored. Okay, let me tell you. See, you have two forms of iron. Okay, there are two forms of iron, sir. What are these two forms of iron? One is heme iron and non-heme iron. Heme iron means that form of iron which you get from animals. Okay, usually the heme form of iron, that is Fe2 plus, which is ferrous iron. You will usually get it from the animals. Okay, from the animal sources, like taking any milk product, cheese, ghee, or like butter, or taking the meat of the animal, chicken. Okay, so from animals you can get Fe2 plus form of iron. And what is non-heme iron? Non-heme iron is Fe3 plus form of iron. Usually you will get it from plants. Okay, you will get it from the plant sources. So usually vegetarians will get Fe3 plus form of iron. The point here which I want you to know is, so which form of iron is absorbed and which form of iron is not absorbed, sir? Fe2 plus form of iron is absorbed. Okay, you can absorb it. Okay, we humans, we can absorb the Fe2 plus form of iron. But Fe3 plus form of iron is not absorbed. Okay, it's not absorbed. So, Fe3 plus form of iron is not absorbed. So, do you think there is a problem? For which people there is a problem, sir? Vegetarians or non-vegetarians? It looks like vegetarians are having a problem, right? But actually no, because vegetarians, even though they get Fe3 plus form of iron, this Fe3 plus form of iron will be converted to Fe2 plus form of iron. The ferric iron is converted back to Fe2 plus form, that is ferrous iron, with the help of acid in the stomach. Okay, with the help of acid, the Fe3 plus form of iron, Fe3 plus, that is ferric iron, will be converted into ferrous iron. Okay, and not only acid here, one more thing which helps here is the vitamin C. Vitamin C, that is ascorbic acid. So ascorbic acid also helps in the conversion of Fe3 plus to Fe2 plus form. Okay. Next, what else I want you to know? Okay, sir, now here is your duodenum. Okay, let's imagine this is your duodenum. Okay. Now in the duodenum, what form of iron is there? Fe2 plus form of iron. Now from Fe3 plus, the iron is converted to Fe2 plus form of iron. Now this iron we have to absorb. Okay, we have to absorb it into the cell first, into this enterocyte. This is your enterocyte. Okay, this is your enterocyte. Now from the enterocyte you have to take into your blood. Okay, you have to take into your blood. From the blood it have to go into the storage sites. Okay, it have to go into the storage site. So how it will occur, sir? Now with the help of a transporter, the iron is going to come into the cell. Okay, Fe2 plus is going to come into the cell. So what is this transporter called as? This transporter is called as DMT1. With the help of DMT1, iron is coming into the cell. Now see, Fe2 plus came into the cell. Now from here, the iron, where it is going? From here, it is going out of the cell with the help of one more transporter. So this transporter that I am showing here, this is called as ferroportin. Okay, this transporter is called as ferroportin. Okay. Now from here, see, the Fe2 plus form of iron will be converted back into Fe3 plus form of iron with the help of a molecule called as hephaestin. There is a molecule called as hephaestin. Sir, this hephaestin is going to convert Fe2 plus form of iron to back to Fe3 plus form of iron. So which form of iron now we are having? Now we are having Fe3 plus. Now this Fe3 plus form of iron, now it is absorbed into the blood. Now here is Fe3 plus. See, but this iron is a free radical. Okay, iron is like a free radical, sir. See, it reacts with the water, like Fenton reaction, and like it's a free radical. It unnecessarily reacts with the cell membranes and causes damage. So what we have to do is we have to bind this Fe3 plus. We have to capture this Fe3 plus. Okay, we have to actually seal it. We have to make it bind with the plasma protein so that now it is not free. Now it is not free, so that it cannot go and do nonsense. Okay. So this Fe3 plus is bound with a plasma protein in the blood. So this plasma protein that I am showing here in the green color, so this plasma protein is called as transferrin. Okay, transferrin, sir. So it's a plasma protein binding with the iron. So in the name itself, it's a transferrin. What it will do? Transferrin transfers the iron. Okay, transferrin transfers the iron to where? To the storage sites. What are the storage sites? Liver. Okay, liver is the storage sites. So transferrin transfers the iron to the storage sites. That's the liver as well as bone marrow. So in the bone marrow, the iron is going to be used in the purpose of for the production of hemoglobin. So iron will be used by the bone marrow for the production of hemoglobin cell. Okay, the precursor cells whatever were there in the bone marrow, they will take up this iron. They will take this iron and they will fuse the protoporphyrin. So iron is going to be incorporated into the protoporphyrin. Now heme is produced. Okay, now the heme is going to bind with the globin chains, forming hemoglobin. Okay, so this is the point which I want you to understand. See, the very important point which I want you to know is, once you have sufficient amount of iron, okay, once you have sufficient amount of iron, this iron is going to give negative feedback. See, the iron is inhibiting the ferroportin. Okay, iron is inhibiting the ferroportin, sir. So this storage form of iron which I am showing here, okay, this storage form of iron, this storage form is called as ferritin. Okay, the storage form of iron is called as a ferritin. So once you have sufficient stores of iron, that iron, what it is doing? It is giving negative feedback to ferroportin. Why? Guys, lifelong remember one point. Once iron enters into your body, it will never come out. Okay, once iron enters into your body, there is no mechanism to excrete the iron out of the body. It's going to stay in the body forever. It's going to be recycled again and again and again. Okay, so you should be very much cautious when to absorb the iron and when not to absorb the iron. Okay, you should be very much cautious, sir. Now, when the person is already having iron stores, okay, when the person is having already sufficient amount of iron, so he doesn't require any further iron, because if he continuously takes the iron, that will cause iron overloaded state and hemochromatosis. Okay, there can be hemochromatosis leading to bronze diabetes, okay, all this stuff. So when you have sufficient stores of iron, the iron which is present in the liver, okay, actually I have to be little more specific, the iron which is present in the liver, now what it is doing? A sufficient stores of ferritin is there, sufficient ferritin is there. Now this liver produces a molecule called as hepcidin. Okay, hepcidin. It is the hepcidin which gives the negative feedback. It's not the iron, just make a small correction. It is the hepcidin, okay, which is coming from the, it is a hepcidin, this one, which is coming like this, and what it is doing? It is inhibiting the ferroportin. The ferroportin is inhibited, so there is no further iron absorption. Okay, so iron is where it is staying. Now iron is staying, okay, it's just staying in the enterocytes. It's staying in the mucosa. Okay, it's staying in the mucosa of the duodenum, staying in the mucosal enterocytes. So this iron which is stored here, okay, it's not entering into the systemic circulation. It's not entering into the body, sir, into the real body. So this iron which is here, this is called as a mucosal ferritin. Okay, mucosal ferritin, sir. Now it's transiently staying over there. Okay, whenever it's needed, now it will be taken into the systemic circulation, from there into the liver. Okay, so this is the normal iron absorption. Iron absorption happens in duodenum. Which form of iron? Fe2 plus form of iron. With the help of which transporter? DMT1 transporter. Moves out of the enterocytes with the help of ferroportin. In the blood, it is bound with which plasma protein? It is bound with transferrin. Transferrin transfers the iron to liver and bone marrow macrophages. Okay, liver and bone marrow macrophages. In the bone marrow macrophages, in which form of iron is stored? Which form of iron is stored? Fe3 plus form of iron. This iron is called as ferritin. Ferritin levels. When you have sufficient amount of iron, liver produces a molecule called as hepcidin. Hepcidin, what it is doing? Inhibiting the iron absorption. Hepcidin inhibits the iron absorption. Remember that point. Hepcidin actually always anti-iron. Hepcidin is anti-iron. Okay. Next, what I want you to know is, next, what are the causes why someone can get iron deficiency? Why someone is getting the iron deficiency, sir? Okay. Causes of iron deficiency. See, adults can get iron deficient. Okay, adults can get iron deficiency from peptic ulcer disease. See, if a patient is having peptic ulcer disease and this peptic ulcer disease is bleeding, okay, there are ulcers in the stomach and these ulcers are bleeding. Okay, gastric ulcers or duodenal ulcers, they are bleeding, sir. If the ulcers are bleeding, means they are losing the blood. If they are losing the blood, means simple, they are losing the iron out of their body. See, continuously they are losing the iron out of their body, that will cause anemia, iron deficiency anemia. So peptic ulcer disease can lead to bleeding. So the bleeding can cause anemia. Simple. Or especially in the elderly people. Okay, very elderly people, there is a chance that they can get the colon cancer. Okay, the patient is having colon carcinoma. The patient is having colon carcinoma. See, colon carcinoma, okay, are the rectal polyps. They can bleed. They can bleed. So any condition which is associated with the hemorrhage can lead to anemia. So the colon cancer also bleeds. If it's bleeding, that causes anemia. Sir, who else can get iron deficiency? Malnutrition. Malnutrition, the person is not taking proper diet. Malnutrition can lead to iron deficiency. Sir, it can be seen in infants. So infants, there is a lot of chance that they can get iron deficiency because infants, newly born, they are taking only breast milk. Okay, they are getting only breast milk, sir. So breast milk is deficient in iron. One of the less available things in the breast milk is iron deficiency. Okay, iron deficiency can be seen in the infants. Next, what else? Proton pump inhibitors. The patient is using proton pump inhibitors, they can lead to iron deficiency because proton pump inhibitors, what they are doing? They are decreasing the acid. Acid is very much important for the conversion of Fe3 plus to Fe2 plus. Okay, for the conversion of Fe3 plus to Fe2 plus requires acid. If acid is not there, the conversion is not happening. If conversion is not happening, that can lead to iron deficiency. Iron deficiency. Okay, what else? So especially females. Females, why they can get iron deficient? What might you think? Sir, females usually have the menstrual cycles, menses. If she is having too much amount of bleeding, okay, usually in that 4 days or 5 days, okay, usually in that 4-5 days, a female is going to bleed between 30 to 50 ml of blood, sir. During menses, how much blood is lost? 30 to 50 ml of blood is going to be lost. If there is more blood loss, more than 70 ml blood loss, that is considered as menorrhagia, excessive bleeding. Now she is having excessive bleeding. That excessive bleeding can lead to anemia. So, menorrhagia. So, menorrhagia can lead to, iron deficiency because the female is bleeding, she is bleeding, excessively bleeding. That can lead to anemia, sir. Okay, so malnutrition, malabsorption. Next, there is a parasite called as ankylostoma. Okay, ankylostoma duodenale. So what is this ankylostoma duodenale? Let me tell you. See, this ankylostoma duodenale, it's a parasite. Where it will live? It lives in duodenum. In the name itself there, see, duodenale lives in duodenum. See, in the duodenum, who absorbs? Sir, duodenum is the place where iron is absorbed. So if a parasite is living in the duodenum, there will be definitely inflammation in the duodenum, inflammation in the duodenal mucosa, so absorption of the substances can be impaired. So this parasite, which is called as ankylostoma duodenale, this parasite, whatever is living, okay, this parasitic thing, it interferes with the iron absorption. Okay, so ankylostoma duodenale lives in the duodenum, causes iron malabsorption. Okay, it causes iron malabsorption, sir. Done. Next cause for iron absorption, iron deficiencies, diseases like celiac disease. So in celiac disease, what happens? So in celiac disease, inflammation. So there is inflammation in the intestines. Okay, celiac disease is an example of like gluten sensitive enteropathy. There is inflammation within the intestines. There is loss of microvilli in the duodenum. There is loss of microvilli in the duodenum, jejunum. So the loss of microvilli in the duodenum, that can also impair absorption of the iron. So in celiac disease, there is inflammation, loss of microvilli. There is loss of microvilli. So no proper absorption of the substances are happening. Not only for the iron, all the substances are not getting properly absorbed. Carbohydrates, proteins, fats, they are not getting properly absorbed. So that will cause malabsorption. It's a malabsorption syndrome, celiac disease. Okay, done. Next, last and final thing which I want you to know for your exam is gastrectomy. Okay, so gastrectomy, sir. See, gastrectomy, what we are doing? We are removing some part of the stomach. Sir. Okay, if you remove some part of the stomach, what happened to the acid production? Acid production decreases. If acid production is decreasing, automatically that will cause iron malabsorption, iron deficiency. Acid is not there. The conversion of Fe3 plus to Fe2 plus is not happening. Fe3 plus to Fe2 plus, if it's not happening, the Fe2 plus levels are not there, so that will cause malabsorption. So that's one cause. Okay, so causes are completed. Now after this, if a patient is having iron deficiency anemia, how the laboratory picture will be? Okay, how the laboratory picture? Okay, the one who is working in the labs, what he will see? See, what happened to ferritin levels? What happened to the ferritin levels? Tell me. See, ferritin is a storage form of iron. Storage. Sir, iron deficiency, no. So ferritin levels decreases. Okay, ferritin levels decreases. Actually, this is the first change. Okay, the first change that will that can be seen in iron deficiency anemia is the ferritin levels decreases. Next, TIBC. Sir, what is this TIBC? Okay, you don't know what is this TIBC, but let me explain you. TIBC means total iron binding capacity. Total iron binding capacity. So, who is going to bind with the iron? Who is going to bind with the iron? Sir, in the blood, the iron is bound with transferrin. Transferrin are like buses. They are like carriers. Okay, bringing the iron to the liver. Now, in the body, iron is not there. Okay, in the body, iron is not there, which is very important. But iron is not there. But so what body will try to do? Body somehow want to get the iron into the liver. Somehow we have to get the iron. So what happened to these carrier molecules? Liver is going to produce more and more carrier molecules, more and more transferrin molecules, so that these transferrin molecules will go and will bind any leftover iron, whatever is there. So more number of carriers. Okay, whenever you are deficient, you require more people. Or for example, you are doing some marketing, sir. Okay, you want to do more marketing, you require more people. In the same way, if you want more iron, you need to get more carriers who can give you the iron, who can bring you the iron for you. Okay, so TIBC, total iron binding capacity, is nothing but they are talking about, okay, transferrin levels. They are talking about what? Transferrin. Okay, so the point which I want you to know is always ferritin and TIBC go opposite. Okay, they will always go in opposite direction. When you don't have iron, you require more carriers to bring the iron for you. And the third one is serum iron. Serum iron. Iron which is present in the serum, sir, not in the bone marrow or not in the liver. It's present in the serum. So this iron will also go down. Why? Because iron deficiency. Serum iron will also go down. Next, fourth thing is free protoporphyrin. Free protoporphyrin. What happened to this free protoporphyrin levels? See, iron have to bind with the protoporphyrin. Iron should bind with the protoporphyrin. Look here. What I have explained you. See, iron have to bind with protoporphyrin for the production of heme. When iron is not there, not available, what happened to the protoporphyrin? Just normal protoporphyrin. It's free. It is not in bound form. It is not bounded with iron. So what happened to the free protoporphyrin levels? It's elevated. Iron is not there, so it's freely there in the cells. So free protoporphyrin levels are going to be elevated. Okay, they are elevated, sir. Free protoporphyrin levels. Next, fifth one is RDW. Okay, what happened to the RDW? So RDW means red cell distribution width. Okay, red cell distribution width. What does this mean by red cell distribution width? See, when you look at the smear, peripheral smear, you will see different sized RBCs. Different sized RBCs are going to be seen, which means some RBCs are bigger in size, some RBCs are small, some RBCs are medium size. So different size RBCs are going to be seen. If you ask me why it is so, see, one RBC is going to stay in your body for how much time? It's going to stay in your body for almost 120 days, almost 4-5 months. It's going to stay in your body. So almost, for example, let's take an average 4 months. It's going to stay in your body for 4 months. Now imagine the person is having initial phases of iron deficiency. Okay, initial phases. Okay, iron is there, but it's going little low. So your RBCs are going to be maintained almost normal size. Okay, almost normal size is maintained. But with the time, gradually, iron deficiency is increasing. Iron deficiency is increasing, sir. Severe iron deficiency, iron deficiency gradually getting severe. So what happened to the size of the RBCs within these 4 months? So RBC size also gradually decreases. So that RBC which is older will be in bigger size. That RBC which is now younger, newly produced, will be in small size. So there is a difference in the sizes of the RBCs. The sizes of the RBCs can be different. So that's why the red cell distribution width is going to be increased, different sized. Okay, different size RBCs are going to be seen. So red cell distribution width is going to be more, sir. Next, the next parameter which I want you to know is percentage saturation. Okay, percentage saturation, sir. What exactly is this percentage saturation? Percentage saturation means to a transferrin molecule. Imagine this is a transferrin molecule. Okay, imagine this is a transferrin molecule. How many iron are bound? Okay, how many iron are bound? If one iron is bound, okay, if one iron is bound, less saturated. If two irons are bound, more saturated. If three irons are bound, more saturated, 75% saturated. If four irons are bound, 100% saturated. Let's see, this is an example. This is an example. Okay, so more the numbers of iron binding with the transferrin, more saturation. Less number of irons, less saturation. Now tell me, sir, in our condition, we have transferrin. Okay, transferrin is there, but iron is there? No, iron is deficient. So less number of sites are occupied. So what happened to the percentage saturation? The percentage saturation of ferrit with transferrin. Now the percentage saturation of the transferrin decreases because iron is not there. Iron is not there, so percentage saturation decreases. Okay. So these are the 6 laboratory changes that can be appreciated. Okay, these are the peripheral smear changes. But what can be seen under the microscope? Okay, under microscopic examination, what you can see? Under microscopic examination, now are you seeing big RBCs or small RBCs? You are seeing the small RBCs. Small RBC. So these small RBCs are, you know already, microcytic RBCs. Okay, so the microcytic. But what about the amount of hemoglobin? Hemoglobin production is going to be less. So pale RBCs. So pale RBCs are called as hypochromic. The color of the RBCs is decreasing. So hypochromic. Okay, hypochromic. So in iron deficiency anemia, the patient is going to have hypochromic microcytic RBCs, or you can say microcytic hypochromic RBCs are going to be seen in a patient who is having iron deficiency anemia. Okay, iron deficiency anemia. So what is the treatment that is done for the iron deficiency anemia? The treatment. So treatment is simple: iron supplementation. Iron supplementation, that is the ferrous sulfate tablets. Okay, ferrous sulfate tablets can be used for the treatment of iron deficiency. Okay. Now the last but not the least, one important point which I want to add here is, so there is a syndrome. Okay, there is a syndrome called as Plummer-Vinson syndrome. Plummer-Vinson syndrome. Sir, what is this Plummer-Vinson syndrome? It's a syndrome, means you having diseases, different diseases will be there in this one syndrome, sir. Plummer-Vinson syndrome, which is also called as a Patterson-Kelly syndrome. Say in this Plummer-Vinson syndrome, the patient is going to have a triad of symptoms. 3 symptoms are going to be seen. One symptom is iron deficiency, sir. Iron deficiency anemia. Okay, the patient is going to have iron deficiency anemia. Second one is esophageal web. Esophageal webs. So in the esophagus, if you look at the cross section of the esophagus, see that's the cross section of the esophagus, sir. Now I am showing you. Now what is seen? What is appreciated? Sir, there is a web, esophageal web. There is a web structure, esophageal web, that can cause dysphagia. Okay, and the third important feature, that is atrophic glossitis. So atrophic glossitis can be seen in a patient who is having Plummer-Vinson syndrome. The reason why I have discussed the Plummer-Vinson syndrome here is, sir, the patients with Plummer-Vinson syndrome are going to have iron deficiency anemia. One more important point which I want you to know is, sir, this iron deficiency anemia patient, what are the clinical features? What kind of clinical features are seen? I have explained you. So these patients are going to have generalized fatigue, lightheadedness, okay, fatigue, irritability can be seen, lightheadedness, headaches. These patients will show some abnormal eating behavior, that is called as a pica. Okay, pica, which means, so we don't know the reason why. In the severe iron deficiency cases, the patients will start to eat like ice, they will start to eat clay. Okay, these things are going to be consumed by the patients. Okay, they are going to take the clay. Okay, they are going to eat something. These substances which usually we won't consume, those substances which we usually won't consume, the patients will start to eat them. Okay, so that's called as pica. Okay, that's one thing which is seen. Patient is going to take the dirt. So something like psychological, right? The patient have to somehow get the iron. Okay, iron is present in usual sand and the dirt, so he is eating something like that. Okay, and that's one thing seen. And physical examination finding. Okay, what you will see on the physical examination finding. So in severe conditions, the nails are going to look like a spoon shaped. Okay, the nails, for example, if this is the finger, the nails are going to become like a spoon shape. This is called as chylonychia. Okay, so chylonychia, sir. So chylonychia is seen in severe iron deficiency. Okay, so with this, iron deficiency anemia topic is completed. In the next video, we will be discussing the second type of microcytic anemia. Okay, that is anemia of chronic disease, and also we will see the sideroblastic anemia in the next video. Hope the video is helpful. Thank you.